Thank you, Bert, and thank you, Manfred, for this very nice invitation. I'm really happy to be here today, and I was really inspired by Professor Butta's lecture. He really, I think, has a vision for women, and I think this is very important because women are really, in many regards, they are not still equal to men in the way they are considered by our society. And there are already many difficult things in a developed country to do for a woman. Becoming pregnant and working is, of course, a big job. I have 2 daughters, and they both study medicine, so I think I was a good example for them because they're following it. But it's very difficult to do everything, and also to try to have a good nutrition at the same time, because one of the problems, I think, in developing countries is that mothers work. And so actually, sometimes for children, it's not so easy to have the same good level of nutrition that my mother gave me because she was not working. So in a way, I think there are many differences in the developing world that we should consider. They're not so simple. But there are also many things that are similar, so sorry for repeating some of the things that Professor Butta already told us, but it will be inevitable. So what I will start from something that I learned actually mainly from Bert and from other colleagues in the Eureka project. It was a big European project. So I really learned that if you want to understand something about micronutrient requirements, which of course are different from macronutrient requirements, you have to first start from an individual level and try to understand what is the minimum amount needed by that individual to avoid a deficiency. But that's also defined by a number of other variables that are depending on the phenotype, but the genotype, metabolism, and health status, and of course pregnancy and lactation make a big difference on all these parameters that are already very difficult. So it's very difficult already in the general population to set rules and to set recommendations which are designed for populations or subgroups, but they are defined so on some bases that are made practically from the, I have to go there if I want to point, sorry. I was trying to. So, okay, so this is a range, a normal range for a micronutrient, and this is considered, this is a value that's the average nutritional requirement or estimated average requirement. There are a number of potential ways to call this, but usually we estimate the proportion of individuals that are below this average requirement as those that are at risk of being deficient. And then we use this average requirement plus 2 standard deviation to evaluate those individuals that instead are over these recommendations, too much over these recommendations, that they could be at risk of having too much of that micronutrient. And then there is always usually an upper level. For example, for folic acid, it's 1 milligrams per day in pregnancy, although it's very debated. So in pregnancy, there are 2 important concepts that I always teach also the students. I know that you all are very well aware of these concepts, but I think we have to consider them. And these concepts are that pregnancy and lactation are not just one time. I mean, during pregnancy, from the first day of pregnancy until the end of pregnancy and then in lactation, the metabolic needs of that woman will change continuously. So in general, from a general point of view, the first half of pregnancy is considered an anabolic condition where the woman sets up the stores that are then used in the second half of pregnancy and also during lactation, because it has been shown very well by animal studies that, for example, the fatty acids that you take in the first half of pregnancy are then used to make milk in the second, in lactation. So, you know, this first part of pregnancy is very important, but also we have always to consider that there is the mother, but there is also a placenta that is, has its own metabolism and turnover and transport of nutrients to the fetus, and all of them have a way to regulate each other during pregnancy. So this is a slide that I always show just to show that there is a preconceptional period also that is very important, because the maternal stores are actually made in the years before conception. And we know very well that the body mass index at conception is so relevant to determine the outcome of pregnancy. But also for micronutrients, this period is very important. So to generalize, there are actually four important outcomes that we want to be very well aware of, and these for micronutrients, and these are embryo-fetal organ development, so the possibility to influence malformations by micronutrients, then also influence in placental function, and by this means influence in fetal growth and what we just heard about, small for gestational age and preterm deliveries. And then we can influence the composition of milk during lactation, and also have, of course, this was a meeting of the Doha Society, so I'm sure you all agree with this potential long-term effect. I had the opportunity to actually review this paper, so I know it very well. Bert wrote a very nice paper on the German recommendations. It was a very nice summary of a number of things, and I very much like this figure that's presented in that paper that's published recently, that shows how in pregnancy the need for nutrients and for micronutrients increases. But look here, this is energy. So it's graphically very evident how the need for energy increases in pregnancy only about 10%, whereas the need for a number of micronutrients increases much more. And particularly for folate, that becomes 50 or 60% more. And for iron, there is a double need during pregnancy than for a non-pregnant woman. And also this is true for zinc and for a number of other micronutrients. Not all of them are listed here, but this is very important to remember. And so let's go into the talk. So there is a very nice paper that just came out recently that made part of my lecture, otherwise it was very hard. So this paper is by a PhD student from Australia, and she very nicely summarized with a meta-analysis of more than 100,000 subjects in developed countries. What is the evidence for the micronutrient intakes that were actually assessed by food frequency questionnaires or by methodologies that were sound? Of course, the studies differ between time of pregnancy when they were done by a number of inclusion criteria that could be very, very wide, but all of them reported micronutrient intake in pregnant women, any age, without date limits, and those that included supplements were actually excluded. First of all, they had to do the work of comparing the micronutrient recommendations across the world. And this is very interesting because these vary very much. And by the way, they're not even all of them, because for Europe, I was very surprised that they were able to find one recommendation for Europe, and this is actually taken from a 1993 publication from the European Community. But you can see that, for example, for calcium, let's start from calcium, these recommendations vary very much between 800 for USA, 500 United Kingdom, 550 in Europe, which is really very low, because now we don't use in Italy this recommendation anymore, and I'm sure most countries have higher recommendations, and 800 again here. Similarly, for iron and for magnesium, there were big differences, and also for vitamin D. So for vitamin D, for example, there was a range, an accepted range between 0 and 10, which doesn't really make a lot of sense. But then countries included in Europe were most of the countries, and they looked at the, I'm summarizing the data for Europe because otherwise there were too many. So if you look for Europe, the results of the meta-analysis comparing the intakes with the recommended intakes, only folate and iron were actually found to be significantly lower than the recommendations. So, and if we look more into detail for folate and iron, now in this slide what we see here is Europe, and this is first, second, and third trimester, and this is a general pregnancy where there were no data. But on generally speaking, the average week was 25 weeks. So you can see that both for folate and for iron, even if we use different recommendations, European or United States recommendations, the intakes that were calculated were much lower, significantly much lower, more than 50% lower than what was supposed to be. So this is similar to underdeveloped countries. There is really apparently no difference in the developed countries for iron and for folate. And so folate, let's concentrate a little on folate. So why do we need to supplement for folate? We know very well already. I don't think there is anybody in the world that is a doctor that doesn't know that folate is important as to prevent a health outcome that is the malformation of the neural tube. And there is a very nice relationship that has been found between the biomarker of folate, that is red cell folate. This is a biomarker that indicates at least 2 months because, of course, red cells are made slowly, and so it's not a serum folate. It's a biomarker of at least 2 months before. So you can see, you know, it's really impressive. Every time I see this slide, I think it's very simple and very impressive how the risk for neural tube defects increases exponentially when the red blood cell folate is below 906 nanomoles per liter. And so, you know, one could argue, well, how many people are below that level? These are data from Germany, and they're really impressive again, because again, you can see here that only 13% of German people this was, okay, a couple of decades ago, but only 13%, I don't think it's better now, were actually over 900, and so all the rest were actually in need of supplementation. Okay, so people in Italy told me when I showed them that slide, well, but this is Germany, and in Italy we eat a lot more vegetables, you know. Okay, let's look at the data in Italy. So these are 3 different studies, all 3 of them from southern Italy. And you can see that the average levels in males and females, so in females, the average levels in Italy for red blood cell, it's here, is around 438, well below that value that I just showed you. And here I'm showing you Chile data and USA data after food fortification. Okay, so sorry to go a little bit in the underdeveloped countries, but USA are not, and so they were actually able to increase their levels. So how much and for how long folate should be given? These data are very interesting because there are not many data about this. So they show that if you give 400 micrograms per day of folic acid, you need approximately 8 weeks to reach that 906 level. And if you give 800, you need only 4 weeks. Then it's interesting that we never really evaluated very well what happens to this curve afterwards, you know? Why? Well, I'll go back to that in a little while. And this study also shows, it's interesting because it shows also in another more statistic way that if you take a typical Western background serum folate of 5 nanograms per ml, an increase in folic acid intake of 400 micrograms per day reduces the risk by about 36%. If you increase it to 1 milligram, then that risk is even more decreased. And if you go to 5 milligrams, you would reduce the risk by about 85%. Just a short 2 slides just to put an input that it's a question mark. So we're always talking about folic acid, but folic acid is actually not the biologically active form of folate. And instead, 5-methyl tetrahydrofolate is the active biological form. So should we give this instead of folic acid? This is a question mark. If you give the same dose, you get a little higher quicker, and you have probably less folic acid not metabolized around, sorry for my English. And in the fetal circulation, what the fetus has and the newborn has in the circulation is actually 5-methyl tetrahydrofolate. And it's interesting to see, I didn't know this, I just realized it when I prepared this talk, that the concentrations are double that in the mother. These are concentrations, not percentages. So the mother has 15 serum folate nanomoles per liter, and the fetus has actually double concentration. It's interesting. So there is a concentration in the fetus. But let's go back a second to how many women are actually taking supplements. Because we know that folic acid is important since the end of the 80s already. And it's very interesting to see that these data start from 1999 to 2011. And you can see that the use of supplements, this is the observed, and this is the adjusted. And it was 40%. It's adjusted for age, for IVF, for previous neural tube defects. So all those women that are at particular risk are adjusted in this curve. So if you look at the adjusted curve, it's impressive how it's decreasing from when probably there was a lot of interest in this, and now people are, as Professor Butta said, people are probably starting to get tired about this information. And again, look here, however, at the age differences. So this is the maternal age, and there is a very low use in women that are below 25 years of age, below 20 years of age, and then it increases and becomes pretty similar after 30 years. Then if you look at the differences related to Caucasian or other, these are all data from London. So you can see that Caucasian women are actually around 35%, which is already low. But in the other groups, Afro-Americans and so on, this is even much lower. So this is, again, related to education, maybe to poverty. But I don't think it's poverty because folic acid is provided for free in Europe usually, in most countries, at least in Italy. In Italy, we give it for free. I'm not sure in London, but I think it's more a problem of education to this. Okay, now let's, I want to show you this more provocative, very new study. I just met Regine Stigers, and she was telling me about this study, so I looked it up. It was just published. And Regina is working in Rotterdam. They are taking a lot of data, many data on, from their fertility unit and periconceptional studies and so on. So first of all, let me tell you that there are many observations already showing that the levels of folate in the first trimester associate with birth weight. So, you know, there is an increase in birth weight if you have a better folate status. But in general, the folate status is not very high. Here, they had a population of women that had very high levels of folic acid, folate in their blood. Because look at this, the lowest quartile was starting from 800 to 1200s, and then the highest quartile was over reaching to 2600. So this is very high folate levels. And so in the green line represents the third quartile. So this is between 1500 and 1800. And the red line is the highest quartile. And this is embryonic growth, crown ramp length. So this is a measure by ultrasound, a very refined measure by ultrasound of fetal growth, embryonic growth, in the first weeks of gestation. And those women that had the highest quartile of folate had a little but significant decrease in embryonic growth. And it was exactly the same difference that they observed for the lowest quartile, which is, I don't know if you can see that there is this line that was not in the previous slide. This line just overlaps with the highest quartile. So it's like a U-shaped curve. So there is probably a way in the middle that is the best for, if we consider that highest is the best, we are not sure. But this was very interesting. This is their hypothesis. They hypothesized that increased periconception red blood cell folate may lead to increased DNA methylation and consequently silencing of imprinted genes implicated in, of course, all the mechanisms that you well know. The other possibility is that high folate levels could downregulate folate-dependent enzymes and uptake, resulting in, again, in the inhibition of growth. So this is a question mark. Another question mark for folate, of course, with the question how much is too much, is whether folic acid has an effect on cancer development. But this meta-analysis apparently in 5 years, with a follow-up of 5 years, did not show any substantial increase in cancer incidence. So this was very reassuring. Okay, I'm done with folate, and I'll just say very briefly something more about iron, although I think I'm not going to say anything completely different from what we already heard. Of course, we know that there is an increased need for iron during pregnancy that is due to both an increase in red blood cells from the mother and increased needs from fetus and placenta. And this, okay. In industrialized countries, we already saw that there is a deficient intake of iron during pregnancy. What is the percentage of pregnant women that have iron deficiency anemia? Well, there is 25% of women that have gestational anemia, and this increases after birth because of the blood loss with delivery to between 25 and 50%. So it's a problem also in our hospitals. I know that in my hospital, we investigated gestational anemia and postpartum anemia many times, and this is practically, even if we supplement, we still see many women that don't take supplements, and there is between 15 and 20% in a very, in a city like Milan, where we're really doing a lot to avoid this. So we have always between 15 and 20% of women that postpartum have values of hemoglobin that are below 8 or 9. So, sometimes we had to give a blood transfusion just a few days ago. I was really sorry for that mother. But we know that maternal iron deficiency anemia is very important for a number of conditions. And also, that it has effects, long-term effects. There are data showing that maternal iron deficiency can be associated with development of schizophrenia in adolescents. So we also know that it's very important to think of how iron, therefore, is transferred from the mother to the fetus, because just again to show you something that is not only related to maternal nutrition, we have published a paper that very significantly showed that the transferrin receptor, which is the receptor at the placental level, that the most important receptor involved in the iron transfer from the mother to the fetus, is significantly reduced to levels that are half of those found in normal pregnancies in placentas of IUGR independently from severity. So these babies have low iron also because their placenta doesn't work well. Why this happens, we don't know, because these mothers were not actually anemic. So it is a problem that can affect the fetus even if the mother is not anemic or iron deficient anyway. In developed countries, we discussed many times also with Millman, we had a workshop whether we should have iron supplementation general iron supplementation, but there are a number of concerns that we could supplement women that have already high levels of iron, and that would not be good for them. So it is wise, actually, if we had enough money, and now with the spending review, at least in Italy, we are asked to decrease the number of exams during pregnancy and so on. But in the optimal condition, the best way would be to screen serum ferritin according to what is written here. You should not supplement women that have serum ferritin because it's the best biomarker of iron status. And if they have values that are over 70, no supplement. Between 30 and 70, you should give 30 to 40 milligrams per day. And if the mother is below 30, then you should actually give a more therapeutic dose of iron. For calcium, we already heard the importance of calcium. Apparently, these data that are again the data from the Bloomfield study that did the meta-analysis of a number of nutrient intakes, calcium in Europe seems to be actually taken up in enough quantities, even if we consider different recommendations, because this is a pretty high value for recommendation. 1200 is, I think it's pretty good. But I think that for calcium we really are in need of individualization, because it's very true that the data, these are the same data that Professor Buta showed us. The data show a significant decrease in the risk of developing preeclampsia or hypertension in relation to calcium intake during pregnancy, whether you supplement or whether you take it. But in Europe at least, there are many women, at least in Italy definitely, that don't take milk. I don't know, why then, when they did that study, they were not able to find all these studies differences. But I can tell you that when I interview my patients, there are many patients, if I ask how much milk do you drink, how many yogurts, they say very little. And they don't get up to 500 maybe milligrams per day. So I think that for calcium we should really individualize, and if a woman has already had preeclampsia, we should supplement, because many obstetricians give medications for avoiding preeclampsia, like heparin or aspirin, and I think calcium is much safer to give if there is a risk in this regard. And okay, this was also already shown. Vitamin D, again, I agree that I don't know why vitamin D seems to be so deficient everywhere. In all countries in the world, whether developed or underdeveloped, these are all developed countries, you can see this really low intake of vitamin D. And so, I think that we should probably discuss whether there should be more need for research in this field to understand whether supplementation should be important. And particularly for vitamin D, there are women that may be at more risk for veiling, or because they are obese, or for a number of risk factors. So my final thoughts, and I am concluding. So I hope I made clear that in developed countries, micronutrient intake seems to be overall within specific recommendations for pregnancy, but definitely not for iron, folate, and vitamin D. So first of all, we should encourage women to establish healthy dietary practice before conception. So before conception means any time, and I agree, really, after menarche, because we never know when a woman is going to be pregnant. And just yesterday I saw another of my patients who is a wealthy person, but she's having her third pregnancy. Her second child was born one year ago. She was still breastfeeding. She didn't take folate. She's very skinny now. And she's definitely not in a very good condition to start a new pregnancy. And I mean, apparently she knew, but I don't know what we could do to avoid these situations anyway. So then we should, of course, supplement all women with folate. And consider, however, that those women that have, particularly those women that are in IVF settings, take folate for many, many, many months or years. And so we should probably understand a little more what that curve is for folate when you take it for so long. Another consideration is that micronutrient supplementation seems to be decreased in the last decades. And so again, what do we need to do at the policy level? And we should definitely work for individualization of supplementation. Thank you.